Good morning, good evening, good afternoon, everybody. It is 11 a.m. in Oklahoma City, 6 p.m. in Paris. A very warm welcome to this new ICH webinar. This is the International Academy for Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it's a real pleasure to have you with us today for what promises to be an exciting and timely session focused on CAR T-cell therapy in the outpatient setting. As we all know, CAR T-cell therapies have revolutionized, I would say, the treatment landscape for several hematologic, mainly lymphoid malignancies. Initially, these CAR T cells were restricted to inpatient administration due to concerns around toxicity and logistics. But these therapies are now increasingly being considered and in some cases successfully implemented. You'll hear about this in the outpatient setting. And I believe this transition from the inpatient to the outpatient setting represents not only a shift in a clinical practice, but also a great opportunity to improve patient experience, reduce hospital burden, and optimize healthcare resources, all while maintaining safety and efficacy. Today, we are very fortunate to be joined by a leading expert in this field, namely Dr. Taha Al Juhaishi, who is an assistant professor of medicine at the Oklahoma University College of Medicine in the United States. And he will share his insight, protocols, real-world experience with outpatient CAR T-cell implementation. I guess we will discover this together. He will likely address some critical aspects ranging from patient selection, monitoring, infrastructure setting, toxicity management, but of course, maybe also financial considerations. So thank you for joining us. And I now have the pleasure of giving the floor to Dr. Al Juhaishi. And please don't forget, we will have a very nice Q&A, live Q&A at the end of the lecture by Dr. Al Juhaishi. So Taha, thank you for joining us, and let's go to your lecture.
Hi, everyone. This is Taha Al Juhaishi. I'm an assistant professor of medicine here at the University of Oklahoma College of Medicine and the associate director of the Transplantation and Cell Therapy program here at OU Stephenson Cancer Center in Oklahoma City, Oklahoma. I'd like to thank the International Academy of Clinical Hematology for the kind invitation to speak about a topic dear to my heart, which is outpatient administration of chimeric antigen receptor T cell or CAR T therapy. I have no conflicts of interest or any relevant financial disclosure with regard to the topic we're discussing today. And my objectives for today is, first of all, is review the literature on outpatient administration of CAR T therapy. So we get a sense of what the state of the field right now when it comes to that. Then review management of treatment toxicity, especially in the outpatient setting. And then at the end, I will reflect on our own experience here at OU Stephenson Cancer Center, as we've been an outpatient CAR T center for a few years now. So background, as I'm sure most of people watching today know that there are currently 7 CAR T therapies that have been approved by the FDA. In hematologic malignancies. We also have one TCR product approved in solid tumors, and we have one tumor lymphocyte infiltrating cell product or TIL approved in melanoma here in the US. The landmark studies for CAR T products included mainly inpatient management due to limited experience with the products at that time, and also because of the potential toxicities associated with this therapy. However, More recent data suggests that less severe toxicities can be now seen with earlier and more optimized use of these products. Also, many centers here in the US and outside of the US have had a lot of experience with both autologous and allogeneic hematopoietic cell transplantation in the outpatient setting. I've listed some of these published reports on that topic, but many centers have been doing this now for years. This is a list of the FDA-approved CAR T therapies here in the US. In red, we have your CD19 targeted CAR Ts in B-cell malignancies. And then in blue, we have the BCMA-directed CAR Ts in plasma cell malignancies. And then we have the TIL product in melanoma, and then the afami-cel or the TCR product in approved in synovial metastatic synovial sarcoma here in the US. And they can all be thought about in the same way when it comes to outpatient administration, with obviously taking into effect the differences in terms of toxicities and some of the other logistics that come into play. I like to also start with this. What is the cellular therapy life cycle, as we call it? Most of our patients, they first start with leukapheresis. That happens outpatient in the majority of situations. Once you do the leukapheresis, the cells, are shipped over to the manufacturing facility. And depending on the product, it can be, 3 or 4 weeks or longer of manufacturing time. Usually during that time, patient is on some sort of a bridging therapy to control their cancer. And once the CAR T product is manufactured and completed, it's shipped back to us, and we start what we call the lymphodepletion chemotherapy, which can be done outpatient. It is being done outpatients at most centers. And then following the LD chemotherapy, you have the CAR T infusion, and really following that is the period for toxicity monitoring. Now, why is outpatient preferred over inpatient? Outpatient provides patients with autonomy and comfort. They can stay in their familiar environments, whether it's their home if they're close to the CAR T center, or a hotel of their choice, or some relative or friend they feel comfortable with. And obviously there's a lot of patient comfort element in doing that. It will also lower healthcare costs. CAR T is expensive as it is, and now we have multiple reports published to support that outpatient CAR T is more cost effective than inpatient CAR T. We will preserve hospital beds, we certainly need those. It will also prevent the spread of hospital-associated infections, which is a rising problem. And then finally, limiting to inpatient care only is not sustainable for the CAR T field, considering the number of products in development, and then the rising number of indications as well. Now, in a really, if we just think about what are the factors that you have to think about when you're considering inpatient versus outpatient administration, and I've listed what I believe are the most important things to keep in mind. First of all is the CAR T indication. Is it an FDA-approved indication, an FDA-approved product, or is it a clinical trial? Is it an oncology, or is it an outside field? Most centers, including ours, and certainly the experience with the initial clinical trials for these CAR T products that we have today, will favor inpatient management, just because, you're not very familiar with the toxicities, and you want to stay ahead of that, especially in the setting of a clinical trial. Number two, patient selection. Age, performance status, comorbidity, especially heart disease and infections, are big factors in determining whether the patient will be safe to stay outpatient or need to be monitored in the hospital. Disease volume has been associated in many studies with risk of toxicities and severe toxicity. So that's something need to be considered. And really, best time for infusion, are you trying to infuse as soon as the cells are ready, or are you have some time to optimize the patient? Uh, there's a caveat to that. You don't want to wait too long and miss the boat potentially on infusing the CAR Ts, but sometimes you have the opportunity to just do some more bridging therapy to optimize the patient and make them more safe for outpatient infusion. Now, prophylaxis against cytokine release syndrome and neurotoxicity or ICANS, this is another big piece to this. Many small studies have looked into that. Maybe the most popular one is the cohort 6 of ZUMA-1 study where they use prophylactic dexamethasone with CAR T infusion. But that's another factor here is, are you going to use prophylaxis? What prophylaxis and why? Uh, or you're going to go with the preemptive management of toxicities. And if you're going to do that, are you going to hospitalize, or are you going to try and tackle these toxicities as an outpatient? What's your capacity for each of these solutions? There's always the element of psychosocial support for the patient, presence of a caregiver, transportation, financial means, education and comfort level of the patient and the caregiver, that matters a lot. Staff and facility support. How is your bed situation looking? Do you have the trained staff, especially if it's after hours? Most of these complications usually happen, later in the evening or early morning. Make sure you have the trained staff available. And then obviously financial coverage and costs of care. For most programs, at least in the US, it makes sense to do this outpatient and not inpatient. Now, quickly, I want to again remind everyone of why this matters, just by talking about CAR T efficacy in relapsed lymphomas and multiple myeloma. So again, this is the famous Scholar-1 study where you see the outcomes for primary refractory large B-cell lymphoma and or relapsed large B-cell lymphoma, especially those that relapse quickly after autologous stem cell transplant. The outcomes were pretty poor, median survival of 6 months or less. Then we have ZUMA-1. You can see some improvement in that EFS, around 30 something percent at 5 years. Following that, we have the randomized trials of CAR T in the second line setting, and you can see in the context of both exa-cel and liso-cel, we have improvement in EFS, and in the context of exa-cel, we also have improvement in OS compared to standard therapy. Now, quickly going over to myeloma, median survival for myeloma now is much longer than what it was, but unfortunately, it's not the case when the patient is triple class refractory or penta-refractory disease. This is a large data set that showed that survival for those patients is around 6 months again. And this is the data for ide-cel, improvement in PFS was very noticeable in the phase 1 study. Same thing was seen with the other product, cilta-cel. And then following that, we had randomized trials, both for ide-cel and cilta-cel, both showing improvement in PFS compared to standard therapies. And now this is, where the field is heading, is CD19 CAR T, and really CAR Ts in autoimmune diseases. We just want to highlight one report that was published in the New England Journal of Medicine last year, showing that patients with autoimmune disease, especially patients with lupus, were able to get into remission and stay in remission following CD19 CAR T. So this potentially will be another domain, another space for us to offer these therapies. And in autoimmune diseases, we even want to be more mindful of toxicities and make it even more feasible as outpatient treatment. Now, moving on to talking about CAR T toxicities, which is the core issue here when it comes to outpatient infusion of this therapy. And really, the recipe for safe CAR T delivery is dependent on multiple factors, you know. As we have alluded to, first factor obviously is the patient. You want to make sure the patient are fit enough to do this therapy. You want to make sure they have a caregiver, they have the psychosocial support they need. They have to stay close to the site for at least 28 days. And we want to do a lot of education, you know, for the patient and their caregiver. You also want to make sure you have the right staff in place, that they're REMS trained. You know, you're going to need your nurses, you're going to need your APPs, your pharmacists, your financial advisor, your CAR-T coordinators. You're going to need all these people, your ICU colleagues. They need to be ready in case, you know, something happens, and things do happen, unfortunately, with these therapies. Uh, then you also want to be ready in terms of management if complications happen. So you want to make sure you have tocilizumab available. You want to make sure you also have the expertise and you feel comfortable. And then you want to also provide oversight and also monitor, you know, your process and troubleshoot and make sure you're constantly improving your processes to work with CAR-T patients. CAR-T toxicities are common and they do happen. This is an earlier report that showed about 80 to 90% of the patients will experience toxicities mostly, and really the toxicities will span almost every organ system. Most toxicities happen within the first 100 days, and fortunately, non-relapse mortality remains low, around 4% or so, so less than 5% in most published reports. This is sort of an overview of what the toxicities timeline should look like. You have, as we all, most of us, if not all of us on the call now know that CRS and ICANS are the most common as toxicities with these, are the unique toxicity with these therapies, and they happen usually within the first 2 weeks. And then you have your blood counts issues, you have B-cell aplasia in the setting of a CD19 CAR, for example. Also, you know, there have been reports about movement disorders and delayed neurotoxicities in the case of BCMA-directed CAR-T therapies, and then second malignancies. So all of these things need to be monitored short and long term. However, for the sake of outpatient infusion, you're really more focused on these things that happen early on within the first 30 days from the infusion. So now moving on to talk about the acute toxicities. We'll first start with toxicities of the LD chemo. I mean, the fludarabine and cyclophosphamide, which is the most common lymphodepletion regimen for most CAR-Ts, both the FDA-approved CAR-Ts and also for most clinical trials as well. And this is not a small dose of chemotherapy, and you know people will have some toxicities. They will have some myelosuppression. Usually 3 to 4 weeks. They might need transfusion. They might need growth factor. Certainly prophylactic antibiotics. So you might you need to be familiar with these things, and but programs that have bone marrow transplant departments or bone marrow transplant programs are very familiar with things like that. But if outside of that, people can get familiar with high dose chemotherapy and complications from that too. GI toxicities do happen not infrequently too, mucositis, nausea. So you want to make sure that patients are being managed for that, especially when they're outpatient and you're not checking on them in the hospital every few hours. And some unique toxicities, cyclophosphamide can be cardiotoxic and fludarabine can be neurotoxic. So you want to also watch for those as well. And renal and hepatic dose adjustment might be needed in some of our CAR-T patients. Now moving on to cytokine release syndrome or CRS, and as you can see here, CRS can really impact any organ, but most commonly what we see, at least in the early phase of it, is fevers, fatigue, diaphoresis, tachycardia, but you know any other organ system can be impacted by CRS for sure. Mechanisms of CRS are, as we understand it today, is a local cytokine release initially happens as a result of the CAR Ts engaging the tumor cells and then interacting with the tissue macrophages. Uh, you have a release of a lot of cytokines, your interleukin 1, your interleukin 2, interleukin 6, your interferon gamma. And then following that, there will be even a bigger release of cytokines that can make it into the circulation as well and lead to the manifestations of what we call cytokine release syndrome. Management, outpatient, inpatient, same thing. You want to rule out other etiologies, especially infections. These patients are at risk for infections. Grade 1, supportive care, but I would argue if you're going to do it outpatient, you might want to have a quick, you might really think about using tocilizumab earlier than later, especially if the patient can have a higher risk for declining and needing hospitalizations and things like that. And then for grade 2 or more, tocilizumab is pretty standard. The IL-6 receptor inhibitor, steroids are commonly used, and then some of the other drugs that could be utilized as well are listed here on this slide. And this is just a quick diagram to show you how to manage these complications. You have your grade 3 and 4 are primarily managed in the ICU at most centers. Then you have your immune effector cell associated neurotoxicity syndrome, or ICANS, or more commonly referred to as just neurotoxicity. Pretty similar pathophysiology. CAR T scan get into the brain and they can release cytokines in the central nervous system, and it can lead to the manifestations of this of neurotoxicity. The most feared of them all is cerebral edema and severe seizures. And I tell most patients, ICANS are mostly, virtually in every single patient will be self-limiting disease. You'll just want to have to, you want to make sure they're safe throughout the process, and also intervene with some of the medications that have been shown to be effective to treat this. Primarily what has been used to treat it is steroids. There is also data as anakinra as a second line, and then some centers now are investigating and using intrathecal chemotherapy for severe cases of neurotoxicity that haven't responded to steroids or anakinra. You also want to not you don't want to forget about other potential etiologies here. One of them being progression of their cancer, and leptomeningeal disease can have a pretty similar presentation. So make sure you do a lumbar puncture or brain MRI, and really rule out infections and progression of the disease as the potential cause. And again, this is just to show that grade 3 and 4 are usually also managed primarily in the ICU at most centers too. And for grading, majority of centers, including ours, we just use the ASTCT grading system now. Now, non-relapse mortality. So when you think about doing CAR Ts as an outpatient and you try to think what are my, beyond CRS, what else should I be prepared for in terms of risks? And now we have data really from a large meta-analysis of 7,000 patients. They looked into 18 clinical trials and 28 real-world studies, and they published their results in Nature Medicine last year. And you can see that exa-cel and cilta-cel were associated with higher non-relapse mortality compared to other CAR T products. Non-relapse mortality was associated with the type of disease. Mantle cell had as high as 10.6% in that data set. Multiple myeloma was second with 8%, and then large B-cell lymphoma had a non-relapse mortality of around 6.1%. And then if you look at the most common causes of non-relapse mortality, you have infections, 50%, and then you have everything else. The cumulative non-relapse mortality from CRS, ICANS, and even HLH is around 11%, and then other malignancies around 7 to 8%, and cardiovascular disease around 7%. So again, you want to be very aggressive with preventing and managing infections, really both inpatient or outpatient administration. You have to always be thinking about this. Now, do we have tools to predict CAR T toxicities or who gets CAR T toxicities? And multiple retrospective studies have looked into this, and uh, there's an emergent theme that from all these studies, things like high tumor volume, whether based off a scan or involvement of bone marrow by leukemia cells, or even as simple as LDH being high. Those factors have been associated with really higher frequency of toxicities and even high severity of toxicities. For those patients, you want to think of very carefully whether they're ready and safe for an outpatient administration. And sometimes this is where the role of bridging therapy can come into play, and we'll talk a little bit more about that in a few slides. But high LDH, inflammatory state at the time of fusion, whether it be at high baseline CRP or high baseline ferritin, low blood counts, especially thrombocytopenia, all these have been associated with higher risk of severe CRS and severe neurotoxicity. This is another data set looking at metabolic tumor volume as seen on PET scan and the risk of toxicities seen in lymphoma patients. And you can see that essentially what it shows that if you have a low disease volume at the time of CAR T infusion, you're going to have lower risk of complications, and even really better survival and better progression-free survival as well. Another tool available for everyone to use is using the ESIC score. The ESIC score is a really validated scoring system for endothelial stress, essentially. And it uses common labs like creatinine, LDH, and platelet. Multiple centers have looked into how to use it or modify it to be able to predict CRS in ICANS, and I have data here from at least one of these reports, and baseline ESIC score combined with ferritin can be used to predict CRS in patients in lymphoma treated with exa-cel, and then combining ESIC score with ferritin and CRP can be used for ICANS. And there are now multiple different other publications in myeloma and lymphoma and even ALL to show similar findings that ESIC score can be helpful for predicting toxicities. What I personally would like to see is more of a incorporating this in prospective studies and actually validating it in that way, so we can have more confidence in the utility of using this. Now, evidence for outpatient CAR T therapy. I want to highlight this publication from the ASTCT, and this is a guidance paper from the Committee on Practice Guidelines published by Dr. Alawali and colleagues in Transplantation and Cellular Therapy in 2023. And really, for anyone interested in learning more about this, I would say this is a great resource where you can have a good overview and then really think about some of the core issues when it comes to switching from inpatient to outpatient process. Also, I have here our report that we published in bone marrow transplantation in 2022, and we went over our experience with the outpatient CAR T here in Oklahoma, and I'll show some of the updated data at the end of this presentation. This is another large report published by Dr. Ahmad from KU, but it was a multi-center collaborative work where they looked into outcomes of outpatient T-cell in non-Hodgkin lymphoma. And you can see here, inpatient, outpatient, there was really no significant difference in terms of progression-free survival and overall survivor. One of the things to highlight about this report too is that at least half of the patients in the outpatient arm did not require hospitalization ever. And so that's, and the people required hospitalization, they certainly needed a shorter duration of stay than if you were to commit to 2 or 3 weeks of inpatient stay. This is another study to highlight, and this is a prospective prospective phase 2 study called Outreach Study. It looked into administration of Lysocell, both in the inpatient and outpatient setting, and at community centers too. And in this study, to highlight, a few things, you can see that, while 126 patients screened, only 100 patients were able to get leukapheresis, and then only about 82 patients received the actual CAR T. So unfortunately, you still lose patients for disease and for other reasons. So there's still room for improvement in the CAR T process overall. But then when it comes to the patients who actually received Lysocell, and it was up to the investigator to choose whether they do monitoring outpatient or inpatient. You can see about 57 of the patients ended up going outpatient, and then 25 patients ended up being inpatient. And this is the main results of this phase 2 study. Again, this is progression-free survival, absolutely no difference between outpatient and inpatient, which is very reassuring to see. Some of the other highlights of the study, there was no grade 3 or higher CRS seen in the study. You could argue that it's the product, the type of product being used, but I would also say, in general, you see it in multiple studies and with multiple products now, that the risk of severe CRS and even severe ICANS is lower than what was seen in the initial studies, just because a little bit more experience and a little bit less disease for many patients at the time of infusion. Grade 3 or higher ICANS was seen in 12% of the patients in the outpatient setting versus 4% of the patients in the inpatient setting. Hospitalization rate was still relatively high, 78%, however, with a short median duration of about 6 days. Most common reason for hospitalization was still cytokine release syndrome and fevers. And then, as I have mentioned, there were really no significant differences in outcomes between the outpatient and inpatient arms. So this being a prospective data set also gives us a reassurance of the safety of the outpatient process. Now I will move on to talk about our own experience here at the University of Oklahoma Stephenson Cancer Center. So some background about the healthcare system here in the state and where we are. So we're the only transplant and cell therapy program here in the state of Oklahoma. Oklahoma has a population of around 4 million people, including 700,000 people in the Oklahoma City metro area. Oklahoma ranks 47th in healthcare. So we're unfortunately one of the states where a lot of issues with healthcare and access to healthcare. There's a lot of cancer. We rank high. We rank really high, 7th highest in cancer in the country, and 6th highest in poverty too. So our patients, they usually come. They have a lot of comorbidities, issues getting healthcare. A lot of them have financial difficulties as well, and you have to deal with all of this to make sure the CAR T process, especially if it's being done outpatient, that it can be safe and effective for that patient. Now, our program has been outpatient from the start, so for more than 5 years now. No planned prophylaxis. We don't use that. We don't use any remote monitoring. I didn't mention that, but there are some small studies published on using remote monitoring, be it new gadgets or vitals monitoring through patches and devices and other things as well. We don't use that in our program. We just rely on the caregiver, just a regular thermometer, a lot of education, and rely on them to follow instructions and to check the vitals, call us if they have issues. Uh, we're able to give all approved CAR Ts, all FDA approved CAR Ts here, in our program. We also have done a lot of investigational products, but as I have alluded to initially in this talk, those are treated differently. Uh, I would caution about doing investigational product all outpatient, especially when it's still a very new therapy. You want to talk with the sponsor and the patient and the CAR T program to make sure everyone is comfortable with the process. And then we have, being in a large academic center, we have 24 hours, 7 days a week, on-call CAR T team from a lot of different folks involved. And we have the capacity to do direct admissions to our bone marrow transplant unit if complications happen even in the middle of the night. So this is the state of the program here. And I'm going to show this data. It's a cohort of about 107 patients treated with commercial CAR T products. Most of these patients had good performance status, so 90% with ECOG of less than 2, 0 to 1, and a median age of 60. Most common indications were large B-cell lymphoma, about half of them, and followed by multiple myeloma, about 26%, and then B-ALL. Most common CAR T product given in this data set was Exa-cel, followed by ide-cel, and then Bruxa-cel. 66% of the patient had CRS, 20% of the patient had ICANS, but really only 10% of the patients with grade 3 or higher CRS and ICANS. So, certainly a manageable percentage of the patients. 26 of the patients developed infection within the first 100 days of infusion. Again, multiple reports on multiple centers show anywhere between 5 to 30% risk of infection. So that really need to be watched and monitored carefully too. 78% of the patients required hospitalization, and really the most common reason for admissions were fever, cytokine release syndrome, and then neurotoxicity or neurological symptoms. There is, room for improvement when it comes to managing some of these toxicities as outpatient, especially CRS grade 1. There is a report by the Medical College of Wisconsin published in Blood Advances that demonstrated, their experience with managing CRS grade 1 in an outpatient unit as well. So if you want to learn more about that, I recommend reading that paper. But really, if you can build a team, for us, it's been more of a staffing issue. We haven't been able to have a 24-hour clinic open 24 hours, 7 days a week. That would help really managing some of these complications outpatient and avoid admitting for many of the low-grade CRS and potentially even neurotoxicity if you develop more expertise and comfort level with that too. And want to highlight that finding caregiver or caregivers continue to be a challenge for many patients that need CAR T. So that's something for us in the field to continue to work on, especially in the outpatient setting. Caregiver is crucial element to make it safe and successful. So this is my approach to who should get it outpatient, who should get it inpatient. So if a patient, an adult patient, there's really very limited data when it comes to pediatric CAR T therapy in the outpatient setting. So for an adult, and I'm not a pediatric oncologist, so I'm not going to comment on that. But for adult up to the age of 65, if they have good performance status, so ECOG 0 of 1, no active infection or really acute organ injury, especially if it's severe, good blood counts, low disease volume, based off their bone marrow findings or their LDH or their latest scan. Certainly, if you have a caregiver and they can stay close to the CAR T, we recommend ideally within 30 to 60 minutes drive from our center. And really good understanding of the process and the potential toxicity. And I would say those patients should stay outpatient, outpatient LD chemo, outpatient CAR T infusion, and outpatient monitoring, be it daily outpatient monitoring for the first 14 days. And then afterwards, this could be even spaced out quite a bit. And then for patients who are 75 or older, there is no age limit for CAR T. So patients, fit patients in their 80s or should get CAR T if that's what they need. But if they're older and they have poor performance status, especially if they have low counts or thrombocytopenia, high disease volume, high LDH, and certainly if you have issues with caregiver and or accommodation, then outpatient CAR T is going to be more challenging. I would still advocate for outpatient LD chemotherapy and maybe outpatient CAR T infusion as well. But then you might want to think about preemptive hospitalization either shortly after the CAR T infusion or at the first sign of toxicities, even if they're mild. And then for everyone else, I will advocate for a discussion, a case-by-case discussion with the patient, with their caregiver, and with the CAR T team to make sure that this is being done safely and aligned with both the patient and the program comfort and goals for the treatment. Some future direction, I think we need to improve access to CAR T both in the US and globally. More can be done in that space. And really overcoming psychosocial barriers like financial coverage, like caregiver, like lodging. These things are continue to be issues that we see with the patients that we treat on a daily basis. And again, to remind everyone that age by itself is not a limit. You really have to look at every other psychosocial factor and their fitness and everything else that we've discussed today. We really need to improve the safety of CAR T, and that's a bigger topic. We need a safer lymphodepletion regimen. We need a safer CAR T constructs, and we really need to generate high quality evidence for management of CAR T toxicities, including in the outpatient setting. That will really help standardize the process too, and give us confidence in the tools we have. And then we need more collaborations with all the stakeholders involved in this, including the payers. Both inpatient and outpatient really have their own logistical and financial challenges, but the goal is really to provide patient-centered care. And this philosophy should prevail and should really guide your decision making here. The take-home messages from today is CAR T therapy is really life-saving treatment, as we've seen both in B-cell malignancies and in plasma cell malignancies as well. It really made a revolution in the treatment of relapsed and refractory B-cell and plasma cell malignancies. The CAR T field will continue to grow and expand, including outside of the oncology space, especially autoimmune diseases. Limiting CAR T therapy to inpatient is neither sustainable nor required for every patient. That's maybe one thing that we remember from this talk is this. Many patients, many reports, our own data, many other centers, at least 20% or higher number of the patients can be completely managed outpatient and would not require hospitalization. Making CAR T therapy more safe and accessible, including through outpatient programs, should be priority in the field. This is, aligned with the better patient quality of life, and then also financial efficiency for both the patient and the institution as well. But thank you for listening. I've included my email here. If you have questions, please feel free to email me. And thank you again to IACH for the kind invitation. And looking forward to any questions and any comments to talk about. Thank you.
Thank you very much, Dr. Al Juhaishi, for really a comprehensive, very well structured, very nice webinar. Thank you so much. And actually, we have already a lot of questions. So I'll start with an important question. We have several questions actually going into the same direction. And this is about the role of telemedicine in the success and feasibility of such outpatient programs. What's your experience? What are your thoughts? What is your advice to the audience? Because obviously, we have many colleagues who were listening, watching, and they were very eager to transfer this into their practice.
Yeah, absolutely. I mean, this is definitely a hot topic now. The way, at least I think about it, and we approach it here as a program is, like there are really two issues here is monitoring and how you're going to monitor. You definitely need monitoring. Patient goes home from the infusion unit, they need to be monitored. Now, there's a spectrum for how to monitor them. We use probably the most basic form of it, which is we need to have a caregiver. Caregiver need to be counseled on what to look for, have a thermometer, have a pulse ox, and check on the patient. And that process has worked for us. And obviously, we showed some of the safety data. Now, on the other extreme from that, there are some institutions who do schedule telehealth visits after work hours to check on the patient. Hey, show me your numbers, show me what's going on with you. And then there's an in between where you have remote monitoring now, whether it's a temperature patch or something like that. I personally still advocate for if you have a good caregiver with at least some basic tools, that's sufficient. Just because you have more sensitive and more aggressive interventions, if you don't prove that it changes the outcome, and the outcome here is not early detection of CRS per se, is that early detection and improvement in morbidity or mortality. Well, short of that, I think you'll add some costs, you'll add some other burden of, services on your team, on the patient, and I don't see it necessary, honestly. That being said, also like if you have, every now and then, like there's always case by case basis, someone who has some issues with their caregiver or they cannot read well or something, and you want the patch or whatever. In that particular case, sure. But one size fits all with these things, I don't think it's really necessary.
Wonderful. Thank you so much. We have a sort of an extension to this question. This is from Dr. Dillard. Can you discuss how you address care on the weekends, holidays, when the outpatient clinic may be closed? I think it's a very
Yeah,
pragmatic question.
yeah, wonderful. I think this is a very important question. And the way I see it, and but maybe I'm biased because I'm a bone marrow transplant physician too. So we've built a lot of this through the bone marrow transplant structure, where we have an infusion unit, a hybrid infusion unit. You can come in when the clinic is closed. You can get checked there, and you can get even IV, fluids or whatever intervention you need, short of like being in the hospital 24 hours. Uh, if you don't have that capacity, then it can be a bit challenging, where to send these patients, you definitely don't want to bring them to the ER. So then you'll have to, something that could be worked out is if you have an inpatient unit and you have an extra bed for obs, they can come in and they can stay there for a few hours to get checked and things like that. But I do highly recommend for programs to develop some form of outpatient infusion unit where you can even treat your grade 1 toxicities there very safely and discharge patient home from there.
Thank you very much. We'll take another few questions, but before this, because we had a request, uh, uh, if you would like to have these slides, you have to make a direct request to Dr. Al Juhaishi. He is
Yeah, absolutely. Send me an email or
you need to deal with him. The ICH does not distribute the slides of the speakers. However, this webinar will be available in the next 24 or 48 hours. Open access, no login, no password on the ICH platform. And You can get CME points. Actually, there will be a few questions you need to answer to get your CME points after watching this webinar. This is ich.org. So let me go back to the questions, Taha. And in line with the question about the weekend and holidays, um, how do you handle, because there is a shortage of beds in most places, at least in my place. So how do
Ours
you
too.
handle the issue of the need for a bed when patients are out? I mean, do you reserve like one or two beds, or how do you manage this?
Yeah, absolutely. That's honestly an area of potential improvement for us too. As we, when the program was built 4 or 5 years ago, we didn't expect the growth and the expansion that has happened so far. So we do reserve one or two beds, but we have more patients outside that if they all have an issue right away and they need to come in, it will be a challenge, and we don't really have the best plan in place to address that. But we need to have a plan for that. And I think one of the things I want to highlight, there's a lot of data on how to prevent severe toxicities. Like I believe a lot in the bridging therapy. I'm one of the people that it might be a bit controversial. I don't infuse the cells immediately for everyone. I do like to have a cytoreduction. I do have to see the patients feeling okay and stuff, and that will prevent severe toxicity. So if they're outside, even if they have something, it's not going to evolve very fast, and you can figure out what to do with them. So that's one thing. Otherwise, like reserving beds is going to be not feasible. Can tell you, hospital administration for sure don't like that. And along the same narrative, we need to, as a field, we need to improve our evidence for how to manage these toxicities, how to predict them. I mentioned the E6 score and things like that. We can come up now. We have obviously like machine learning and some other better tools to predict, issues and when they can happen and how bad they can get. We have to take advantage of that. Just having beds available is not the way to go, although we do that.
Okay, another question, and this is actually in line with, I think, one of your last slides, I believe. So someone noticed this on your slide, and you mentioned that the outpatient setting will likely help to improve the quality of life of the patient. And here I think there is a sort of a controversial issue. What is the evidence that actually the outpatient setting can improve quality of life? And we have a remark here from a member of the audience saying, well, maybe the level of anxiety will be very high in the outpatient compared to the inpatient. What are your thoughts? Do you have data about this?
Yeah, no, great question. So I can tell you like the my interpretation of the evidence and then my personal, belief from treating patients every day, with these things. Uh, the data, in all honesty, I think it's probably like kind of bit debatable because it comes down to the what are you using to track patient-reported outcomes on these things, and how often have you done it, and what's the actual setting and all these things. But I do see it as more in favor of outpatient versus inpatient. And that's not CAR T, which is not less studied. That's just oncology in general, including transplants and things like that, where there's a little bit more data. So I do interpret it as more in favor of outpatient. Now, when I treat patients in clinic, yes, they are anxious. Uh, they read and stuff, but we have evolved as a field. We have evolved. We know more. We know more than 5 years ago. So we calm them down. Like if you come into this CAR T with a clean pet, and you're otherwise healthy guy, fit. I calm them down. We this is a lot of the stuff we do is is just reassure the patients. Hey, you're gonna still come every day. You have your thermometer, you have your caregiver. We have a telephone covered 24 hours by our charge nurse in the inpatient BMT unit. They're like, if you're not sure, just call us. Call us, let's talk. And we found that to be very effective. Patients can still be, we don't want them to be anxiety free either. And they're like, no, I'm gonna miss my appointment tomorrow. I'm fine. We don't want that, but we don't want them to be like, too anxious for no clear reason. Uh, and if I'm anxious because of some of the metrics, ideally evidence-based metrics, tumor volume, type of product you're infusing, other issues with the patient, then I'm going to err on the more conservative side. I'm going to probably preemptive admission or preemptive intervention, uh, things like that. One more thing I also want to highlight, because it comes up a lot even in meetings, is the prophylaxis. Whether you want to follow the cohort 6 and Zoom 1 and do steroids for 3 days, or you want to do a prophylactic TOSI. Our interpretation of the data here is this is mixed. We do worry about the CAR T efficacy. These are small studies. So I think preemptive intervention is better than prophylaxis. At least this is how we interpret it here. And the nature of prophylaxis is, if you're going to do one size fits all and give everyone a prophylaxis, then you for sure over-treating some patients. But maybe you can do select prophylaxis where someone, let's say a mantle cell getting Brexucell with a lot of tumor volume, they will have high risk of severe CRS and ICANS. Those are the patients that can consider prophylaxis, but saying every CAR T patient should get prophylaxis is not something, I don't think it's needed.
Excellent. One last question from Dr. Eric Ertz from Zurich. Hi, Eric, and thank you for the question, because Eric is a good friend, and he was a few years ago the head of the nursing group of the EBMT. And his question is about whether you have already experience with CAR T cells in melanoma or autoimmune diseases, and in the outpatient setting, of course.
Yeah, so great question. In the works. Hasn't happened. So two things to say about that. The autoimmune, they're still on clinical trials. So we will work with the sponsor and make sure that we do this because we have to document things in a timely manner, among other things. So maybe at least starting inpatient to make sure we're very fully aware of what's going on is the way to go. That has been our approach with the clinical trials, that we're kind of like neutral. We start inpatient, and after 2-3 patients, we can switch outpatient if we feel comfortable. The melanoma product, the TILs, what I'm assuming we're referring to, the problem is going to be the IL-2. The IL-2 that you have to give the patients after the cell infusion, that's going to be exceedingly difficult to do it outpatient, both like logistically and safety-wise. But beyond the IL-2, if they're okay, I think you can be monitored outpatient. That's the other thing that I want to highlight. We need obviously safer constructs where, like, the people have, as people have experience. There's a product approved that they fractionate the dose in BALL. So maybe, some of these strategies, when are you giving the cells and how much of the cells and what other therapy you're giving and at what time point is probably the way to go to address some of these things.
Excellent. Thank you very much, Taha. This has been a lovely webinar. And as we come to the end of this webinar, I want to sincerely thank each of you for your time, your engagement, your questions, and your commitment to advancing patient care. I think today's discussion on the outpatient use of CAR T-cell therapies has highlighted not only the remarkable progress we have made, but also the importance of innovation, collaboration, and adaptability in transforming how we deliver cutting-edge treatments. And this transition to outpatient CAR T therapy is not just a shift in logistics, it's a bold step toward more patient-centered, accessible, and sustainable cancer care. So let's continue like today to share experiences, to learn from each other and push the boundaries of what's possible. And here, I'd like to take this opportunity to highlight the wide range of high-quality educational activities offered to you by the International Academy for Clinical Hematology. We do have a very dynamic platform, ICH.org. We provide free and open access to a wealth of resources, including webinars for physicians, nurses, pharmacists, journal clubs, case-based discussions, dedicated tracks, the ICH Transmit Academy, the ICH Myeloma Academy. And all of these resources are actually, most of them are being now translated into Spanish and Chinese. And these resources are designed to promote continuous learning, to foster global dialogue, and support clinicians and researchers in delivering the best care to patients around the world. So we warmly invite you to explore the ICH platform and make the most of this valuable content. Thank you again for being with us today. Thank you, Dr. Al Juhaishi, and until next time, stay safe and stay inspired. Bye.
Thank you, Dr. Mahdi. Thank you.